What's up, future respiratory therapists? In this video, I'm probably gonna go off a little bit. I just can't help myself. You don't wanna miss it. Let's dive in. What's up, future respiratory therapy community? Today, I kind of just wanna have a conversation, kind of blend the spectrum of just talking, kind of a little bit of education. We're gonna talk about short-acting beta agonists, a little bit of pharmacology, a little bit of pulmonary function, and a little bit of mechanical ventilation. But really, we're going to talk about the transition from pre-COVID to post-COVID respiratory therapy. Now, when I say that, what I'm talking about is if I go back to 2019, remember, the pandemic hit in early 2020. So we go back to 2019. We found respiratory therapy. And when I say 2019, I'm talking about 2019 and as far back as you can remember. Respiratory therapy was rooted in this idea of productivity. We were focused on completing treatments. The amount of aerosolized medication that was happening was ridiculous. Now, some places might have had protocols in place that reduced this, but there were still elements and there were still places and facilities that were giving a tremendous amount of aerosolized medications. And when I say aerosolized medications, of course we have our inhaled corticosteroids, Pulmicort. Of course we have Brovana. But the most prevalent drug that we aerosolize from a respiratory therapy standpoint is by far Albuterol. Everybody knows that. We're either aerosolizing Albuterol or Xopenex, Q4 to Q6 hours, maybe QID. Now, my question is, and what I've been saying for over a decade now, is why? Why are we giving and aerosolizing so much Albuterol? I know, because it cures everything. Everything from status asthmaticus, to emphysema, to pneumonia, to atelectasis, to a stumped toe. I know that. But really? Why have we not reined this excessive amount of aerosolized medications? Why was there never a call for it before? Now COVID hits, okay? Now let's go to February, March of 2020, and COVID hits. And suddenly, we stop aerosolizing medications. Now, of course, there's some patients that still get it. But for the most part, COVID drastically reduced the number and the amount of aerosolized short-acting beta agonists that we're giving. Now, this is interesting to me because you could have data and data and data upon data and data for the previous decade that supports that there's only one indication for a short-acting beta agonist. First of all, let's stop right there. What is a short-acting beta agonist? So when I say SABA, this is short-acting beta agonist. I'm talking about Albuterol, and I'm talking about levalbuterol, okay? These are your short-acting beta agonists. There's only one indication. It's documented. It's proven. This is not for discussion. The one indication for this drug or for drugs like this drug is simply this: the presence of airflow obstruction. That's it. That's the indication. Presence of airflow obstruction. And some even take it a step further and say the presence of reversible airflow obstruction. That's your indications for albuterol, your short-acting beta agonists, your adrenergic drugs, your sympathomimetics. All of that means the same. So how did one virus come in and suddenly reduce the need for all of these aerosolized medications? We were doing treatments out the wazoo. I can tell you before I have stacked 80 to 90 treatments in a 12-hour shift before. This is before I found my true way as a respiratory therapist and realized that that's not the respiratory therapist I want to be. That's not the way I want to practice. It's not the type of patient interaction that I want. I don't want to put a mask on a patient, walk out the room and come back 15, 20, 25, 30 minutes later, maybe not even come back and let someone else take the mask off. But there was a time when that's how I practiced. And there was a time when many respiratory therapists practice that way. So hopefully some of you looking at this going, what? I don't even know what treatment stacking means. Well then good, stay in that mindset. But if you know what treatment stacking is and you know you do it or you ever have in the past, then you understand what I'm talking about. Now the key here is that in most of those patients, and I worked primarily trauma ICU, and I worked primarily with trauma patients in the post-ICU unit. I'm talking about 20, 22, 24, 25, 35, 40-year-old, 50-year-old patients who motorcycle accidents, motor vehicle accidents, whatever it might be. Very few of them actually had an underlying pulmonary disorder. Yes, there was an occasional underlying COPD that came in from a car accident. Of course, that always happens. Yes, there was an occasional status asthmaticus that came in that fell off a bicycle. Of course, I'm talking about majority. Majority of my patients never had an underlying pulmonary disorder, yet they were all receiving Q4 to Q6 hour albuterol via SVN. Now what? Like, let's go back to the indication here. The presence of airflow obstruction with an emphasis on reversible airflow obstruction. That's what the pharmacology says. Why were we giving all of these patients treatments? I do not know. And I'm thankful for what COVID has done in reducing the amount of these therapies that we're given, because no one else could show this and no one else could demonstrate this. Despite the research, no one else could demonstrate that this was not good practice of medicine. Every therapist knew it. We just give them albuterol, It didn't matter. Me and another fellow therapist, when I was working at the bedside in that trauma ICU, we used to laugh and carry on about this when we were charting. We used to say breath sounds pre were clear, breath sounds post were clearer because of the albuterol. They were clear before, and afterwards they were still clear, but we used to say clearer. And sometimes we add 3 ers on the back of it. Clear. Like, well, what's the goal here? If you're giving somebody a short-acting beta agonist, then you have to ask yourself, why am I giving it? Is there an indication for it? And the only indication, again, is this right here. So how do we define this? How do we define the presence of airflow obstruction? Well, it's very simple. You use a spirometry. So let's talk about spirometry for just a second. Spirometry. When you use a spirometer, you are assessing expiratory flow of gas. So this is expiratory airflow. That's what it comes down to, okay? Now, to identify an obstruction, you are going to assess your FEV1%. If it's less than 70%, it's indicative of an airflow obstruction. This patient perhaps would benefit from a short-acting beta-agonist drug such as albuterol. This is true. Less than 70%, you got an obstruction. What's the obstruction? Is it bronchospasm? Probably going to be supported with breath sounds that reveal expiratory wheezes. But nonetheless, you have objective data. This is key. Objective data. This is data that nobody can dispute. A patient has an FEV1 of FEV1%, less than 70%. No questions asked. There's an obstruction of some sort. Okay, this is an indication for a short-acting beta agonist. Now, did the short-acting beta agonist, did it help? That's the question. Because see, we do therapies, and the idea of doing therapy is that we help the patient. So when we do therapy, do we assess if the therapy helped? Well, if your pre-spirometry shows an FEV1% of less than 70%, and then you do a breathing treatment with a short-acting beta agonist, then you should do a post-assessment. If that therapy helped, you would see a greater than 12% improvement and 200 milliliter improvement in your FVC or your FEV1. So you see, now I have data. See, now I'm actually critically thinking and providing care based off of a need and an indication, performing a therapy, and then assessing a post-therapy. Now, the purpose of this post-therapy assessment is, did my patient respond? Was the therapy helpful or not? I cannot tell you how many treatments I did over the years. I just gave therapy. I just gave treatments. And some of you right now are just giving treatments without really thinking, is there an indication? And if I still give it, is there improvement afterwards? So I hope, my point in this is hoping that this movement that COVID has created with drastically reducing the number of aerosolized medications, there's still a lot being done. But even if those percentages, do those need to be done? I'll tell you right now, I'm seeing it, I'm working with it right now, and I'll tell you that I think not. I still think there is too much aerosolized albuterol being given based off of this type of data. Now, I know what some of you are thinking. Well, what about the mechanically ventilated patients who can't do spirometry? It's a fair question. Let me show you how we would assess that patient. If you had a patient on mechanical ventilation, then we can assess airway resistance. How do we assess airway resistance when a patient is on mechanical ventilation? Multiple ways. One of those ways is by actually doing the calculation, which is PEEP minus PLAT divided by flow in liters per second. If a patient has a bronchospasm that is going to respond to an aerosolized bronchodilator, then before you give that therapy, there should be some level of increased airway resistance. Right? This makes sense? This formula right here will support that. Furthermore, you can simply look at your pressure waveform, and if you ever observe something like this, this is PIP, this is PLAT, and you see this big difference here, that is reflective of airway resistance. Why? Because the formula states PIP minus PLAT divided by flow in liters per second. You have a patient who has a pressure waveform like this. Well, there's a very small difference here. This patient does not have an airway resistance problem. This person has more likely a compliance problem. Albuterol does nothing for compliance in terms of static compliance or alveolar compliance. It will help with dynamic compliance because dynamic compliance includes airway resistance. It does nothing for static compliance. So why are we giving this person right here albuterol Q4 when there is no evidence of airway resistance? Furthermore, you can also assess your flow volume loop. Now, a normal flow volume loop on a ventilator should look like this. But if your patient presents with something that looks like this, and you see that scoop in the loop, that's indicative of an airway obstruction. Now let's say you see this, but your patient has coarse crackles. Then most likely the secretions are causing the obstruction. And in that case, you should probably suction your patient. But if you see this and your patient presents with expiratory wheezing, then it's probably bronchospasm. And yes, 100% every single time, an inhaled aerosolized short-acting beta agonist would be indicated for that patient. Now the key here is that yes, the indications are here. So let's just say that we have indications. We have increased airway resistance and we have obstruction visible on our flow volume loop. So yes, we have an indication of some sort of airway obstruction supported with breath sounds of expiratory wheezes. So we know the patient doesn't need to be suctioned. We need to give a short-acting beta agonist. You do that, okay? Give your breathing treatment. Give your aerosolized medication. But then reassess all of these things. Your airway resistance should reduce. Your scoop, when you look at your flow volume loop, should return closer to normal. It may not be exactly normal, but it should return closer to normal. The scoop should be diminished, in other words. It should get more close to normal. And this supports that the breathing treatment, the inhaled short-acting beta agonist, actually had some benefit. And now we're not just wasting our time. See, the reason I'm talking about this is because inhaled aerosolized short-acting beta agonists, when given to patients that have no indication for it, and I'm not talking about, you guys understand, I'm not talking about status asthmaticus, I'm not talking about your COPDers who have an indication for the medication. I'm talking about your pneumonia patients, your atelectasis patients, your pleural effusion patients who are tachypnic, and maybe they're not oxygenating real well, and somehow an order shows up for albuterol Q4, Q6, QID, whatever it might be. I'm talking about those patients. Why are we doing that for those patients? You understand, I'm going to take you way back to the very beginning of your educational process. That's what we call a misallocation of therapy. That's what we call spending healthcare dollars to provide therapy that poses no benefits. Now, COVID has helped us. My question is are we as a profession going to be strong enough to not revert back to our pre-COVID ways? COVID has completely reduced drastically the amount of aerosolized medications, and rightfully so. But it's also highlighted the fact that so many of those therapies for so many years were never needed in the first place because outcomes have not been affected by this change. By this drastic reduction in aerosolized medications, it's not like people are having to stay in the hospital longer for pulmonary complications. No. So my question is right now, we're at a point of opportunity as the field of respiratory therapy. We're at a point to where we can move forward in what we has happened from the pandemic and from understanding these things right here. I will tell you right now, it is my honest opinion that for any aerosolized short-acting beta agonist to ever be given in the future, these things would have to be documented and would have to support the need for the therapy. If the indication's not there, we're not giving the therapy. If the reversibility doesn't show to be beneficial, we're not giving the therapy. If there's no change post, we're not giving the therapy. That's truly how I feel right now. And I'm just really speaking honestly to you right now and just want you to understand that this is where we are, to where we actually can get away from being known as people who give breathing treatments. That has always been, if you ask somebody 10 years ago, what's a respiratory therapist do? I guarantee you the first words out of their mouth, or at least the first 10 words out of their mouth, will be, oh, we give breathing treatments. If you ask somebody who's not a respiratory therapist, what does a respiratory therapist do? First words out of their mouth would be, oh, they give breathing treatments. It's not what we do. We maximize ventilation. We maximize oxygenation. We focus on alveolar recruitment. We focus on the mobilization of secretions. And yes, we treat bronchospasm, bronchoconstriction when it's present. But to wrap us up in a title that says, oh, you give breathing treatments, that's what we were known for. No longer. We have got to move forward from this. We've got to grasp this opportunity we have, and we have to redefine what it is that a respiratory therapist is and what it is that a respiratory therapist does. We optimize external respirations for the sake of optimizing internal respiration. That's what a respiratory therapist is, and that's what they do. Now, I want to talk about one more thing here. Now, we got lots of treatments here going on, and COVID has changed the landscape. But I understand that there are facilities out there during this pandemic that have called on the help of physical therapy and occupational therapy to come aid in the delivery of respiratory therapy services. I just want to tell you right now, what is that all about? You're telling me that in a moment of time, for the field of respiratory therapy and respiratory therapists that have been in the field for 5, 10, 15 years, who have always said, I never get the respect I deserve. Your time to shine shows up and we give work away to other disciplines? And don't get me wrong, I love physical therapy and I love occupational therapy and speech therapy. I love all therapies. I love what they do. I respect them for what they do. But what they do is not what we do. How are we justifying this? How are we justifying giving therapy away to other disciplines in the middle of our time to shine? We're short-staffed. I get it. You know why we're short-staffed? Because we're misallocating therapy like this. I would even argue that a physical therapist doing an inhaled aerosolized medication is a misallocation of therapy. And that doesn't even make sense. Just flip the script for a minute. Let's just flip the script. Let's just say that we're in a pandemic and physical therapy is saying, we need help. RTs, respiratory therapists, come help us do our job. Most of us would all do it. Because why? Because we're team players. But you're going to tell me you're going to go walk a patient or you're going to go move a patient? You understand the intricacies of physical therapy to the point that you could perform their job? That doesn't even sound fair to a patient. Much less a paying party who says, oh, they got this therapy? Oh, fantastic. They got physical therapy performed by a respiratory therapist? Wait a second. Time out. Is that the way that works? Like, what really is going on here? Like, who? I want to know in the comments below. I really want to know. I'm serious. I really want to know how many people are working in facilities where respiratory therapy services have been handed over to physical therapy and occupational therapy so that the respiratory therapist, in all credit and all fairness, can focus on the COVID patients. I understand it's a viable alternative, but it does not seem like the alternative that we need to take us into the future. I feel like we're on the cusp right now. I feel like COVID is a terrible thing that has just jacked up everything, but we're on the cusp right now. We're on the cusp of being in a state of an opportunity. Crisis usually presents opportunities, and us as respiratory therapists in the forefront, in the spotlight, going, oh my gosh, I don't hear anybody ever go, oh my gosh, respiratory therapy, that's so important right now. I've never heard that before. Now I'm hearing it all the time. So you're telling me on the cusp of moving forward and being something great and redefining our profession based off of something other than aerosolized medications, we're giving stuff away? That sounds like we are one step away from going forward and also one step away from not being needed. I don't know about you. That's just my take on it. I just see the present state of opportunity, and I'm just going to urge all respiratory therapists, all future respiratory therapists, to keep your eyes open to what you're getting into. And it's on us to grasp this moment and to take advantage of this opportunity. We have a tremendous opportunity in front of us to move our field into a direction focused more on critical thinking, ventilation, oxygenation, alveolar recruitment, getting away from being known as aerosolized medication specialists or inhalation therapists, which is what we were once known as, which we never really got away from. We just changed the name to respiratory therapist. We were, for the most part, still giving a crap ton of aerosolized medication that had no bearings on outcomes, no positive benefits to the patients, and if nothing else, just created and posed more risk to our patients with no possibility of positive effects. I just want you to think about this. The purpose of this video is to think about this. What are you going to do with this opportunity? You're going to squander it? You're going to give your work away? You're going to let PT, OT, and other therapy services do our job? Or are we going to freaking step up and take this opportunity to move us forward? I hope this makes sense. I look forward to the comments because I think this will lead to a fantastic conversation. If you haven't subscribed, please do so. And in the end, I just want you to remember that average is easy, so don't be it.